Okay, this morning we have Dr. Diana Bienvenu, who is a clinical professor of pediatrics, will be our presenter. And Dr. Bienvenu has been on our faculty for more years than you care to count, and trained here for a good while. And she is one of the world's experts on breastfeeding and breastfeeding support for moms. And she has served on the American Academy of Pediatrics Committee on Breastfeeding at the national level for a couple of terms. So we'll let Dr. Bienvenu take over.
Okay, as I tried to decide what I was going to do this talk on, going back and forth between many different thoughts, on Sunday, April 1st, Dr. Bocchini's birthday, by the way, in the Shreveport Times was this article, Louisiana Mothers Donate Breast Milk for Ill Infants, talking about the establishment, formal establishment of Louisiana's first human donor milk bank at Ochsner Baptist Hospital in New Orleans. So it reminded me of a case we had very recently in the nursery that I'm going to tell you a little bit about. I'm not going to go into a lot of detail, but this happened recently. We had a young mother come in, this in labor, active labor. This was not her first pregnancy. She had delivered before here and successfully and had a C-section that time. This time she was trying to deliver vaginally, and they gave her a trial of labor, and she had some blood pressure issues during her labor, and this baby just wouldn't descend. And so they ended up taking her back for cesarean section after about 3 hours in stage 2 of labor. And in the process of this cesarean section, there were some issues with very significant bleeding. The baby was delivered, and she had told us ahead of time. We knew that she wanted to exclusively breastfeed this baby. She had exclusively breastfed her previous children. And but with the problems that occurred with this delivery, the baby, she was able to see the baby just for a minute or so, and the baby was brought to the KDC while the obstetricians continued to work with this mother. During that time that OB was working with her, she had more complications that I'm not going to delineate more than that, but these required that she be urgently intubated and have emergency surgery performed. So this occurred, and needless to say, she couldn't breastfeed on the table, which is our standard here, and the nurses came out and informed the family that there were some issues with the mother, and she was going to be back in the delivery room for a longer period of time. Now, in the meantime, the baby was doing fine. The baby had APGAR scores of 8/9 and looked great, but was a big baby, large for gestational age. No diabetes history in this mom, but this was a big baby. And so my concerns were that we were going to have a baby who was going to need feedings at some point in time, probably sooner rather than later because of the baby's size. And a relative of this mother was there, waiting for the delivery, this happy event to occur. And this relative had delivered here not too many months before, and I was aware of this relative's health history, and this relative was exclusively breastfeeding her now several-month-old child, and also knew that this new mother wanted to exclusively breastfeed. And when I talked to the husband about the fact that we were probably going to have to give this baby formula, she came over and volunteered to breastfeed the baby instead. So, what do we do? I don't have any conflicts of interest. We're going to talk about changes in infant feeding over a long period of time from both the historical and social perspectives, and we're going to compare formal milk sharing to informal milk sharing. So we've talked about the case, and this gesture by the relative of this young woman is a classic case of this relative offering to be a wet nurse for this young mother. And what is a wet nurse? A woman who directly breastfeeds another woman's child. It's a common practice with written records about wet nursing beginning in ancient times. And initially it was very much a need for survival of infants. Jewish tradition documented from 2000 BC was that breastfeeding was considered a Jewish religious obligation. So if the mother was unable to breastfeed, a wet nurse was used. In the 1500 BC, the first written medical encyclopedia, the Papyrus Ebers, had written prescriptions for lactation failure, and if the remedies didn't work, then it was recommended that a wet nurse be used for the mothers. But over time, wet nursing changed from always being a need to more commonly becoming a choice, a lifestyle choice. And this occurred around 1000 BC. Initially, Greek women of higher social stature demanded wet nurses, and these wet nurses themselves became elevated in the hierarchy of society, and they had authority over slaves in that time period. And it was not uncommon in around 400 to 300 BC that wealthy Romans would purchase abandoned children, frequently female infants, at very low prices, with the plan that when these infants became older, they would become slaves for the family. And so they were purchased cheaply. The wealthy Roman family also hired wet nurses to feed these abandoned infants, and the infants were breastfed then until they were approximately 3 years of age. And then again, they're established within the household, they grow a little bit older, and they become slaves themselves. In about 100 AD, qualifications started appearing in the written literature for what a wet nurse should have. And one of them is the fingernail test. Soranus of Ephesus devised this, and it actually continued to be used for about 2,000 years, really until the 1800s. And with this fingernail test, a drop of the mother's milk was placed on the mother's fingernail. And it was supposed to be that when the finger was moved, that the milk would not be so loose or runny that it would completely cover the fingernail. If it did, then that was not good. It was too thin. And also, when the finger was turned over, that drop of milk also should not be so thick that it did not fall off. So the quality of the mother's breast milk was such that, of the wet nurse's breast milk was such that it should not be too runny and should not be too thick. And so this was used, like I said, for the next about 2,000 years. And then Oribasius, who was a Roman who lived in the 300s AD, he said that a wet nurse should be a healthy 25 to 35-year-old woman who had recently delivered a male child. Not female, but male. However, few hundred years later, some objections to wet nursing started appearing. People started being concerned that breast milk has magical properties which could transmit both physical and psychological characteristics of the wet nurse to the baby, and this would not necessarily be a good thing. And then in the Middle Ages, there became a concern that the infants would love the wet nurse more than their own mother because it was the wet nurse who was providing the nurturing and the care for the infant much more than the mother was providing that. Then in the 17th century, even more concerns appeared. One was that the wet nurse might switch her own baby for that of this wealthier family, and so that her own child would be raised as the son or daughter in this wealthy family and have all the benefits as a grown-up of that upbringing, and didn't really matter that then the wealthy family's child would live in poverty. Also, again, the continued concern that affection felt between the mother and child would be diminished. They talked about the worry that the child might inherit a bad condition from the wet nurse. Now, I'm not exactly sure what bad condition might be, but this was one of the concerns. And that also that the wet nurse might have an imperfection that could be transmitted to the child, who could then transmit this imperfection to his or her parents. Also, it was said that the wet nurse should be happy, should be healthy, should be conscientious, well-behaved, observant, and sober. And definitely a wet nurse should not have auburn hair, because redheads were known to have a hot temperament that was harmful to their milk. During the Renaissance, wet nursing, however, it did continue to be pretty popular, and in the Renaissance ages, wet nurses in France were well paid and became a highly organized profession, especially for poor women who didn't have many means of employment available to them. And so they were registered with the Municipal Employment Bureau. French law required a medical exam of these women and forbade a woman to breastfeed another child until her own infant was 9 months old. And I suspect that may have had something to do with the concern about switching infants, but also wanting to make sure that her milk was of a good quality, so that if her own child was thriving by 9 months of age, then certainly when she was acting as a wet nurse, her milk would provide quality nutrition to the child she was nursing. Also during this time, aristocratic women didn't want to ruin their figures, and their husbands didn't want them to ruin their figures. So their husbands actually dictated the feeding choices of the women in this time period. And so many times the husbands wanted a wet nurse employed. Also, the clothing of the time did not easily allow for a woman to breastfeed her own child. And in the middle class, the merchant societies, the doctors, the lawyers, many times it was the mother of the household who ran her husband's business, and as she also ran her household. And it was cheaper for them to hire a wet nurse to nurse the new baby than it was for them to hire someone else to run the business of their husband or to run their household while they were occupied with nursing their own child. Then the Industrial Revolution came in the 1800s, and wet nursing shifted from wealthy families to laboring lower income families who were relocating from rural areas to more urban areas. There was an increased cost of living doing this, and families became poorer. Also, the wages were poor for these rural folks who were moving to the cities. And so mothers were being forced into the workplace to contribute financially to their families, and they couldn't breastfeed or take care of their children. So they would farm out their children to destitute peasant women who were supposed to obtain a license from local authorities and report the deaths of any infants in their care, but those laws were usually ignored, and infant mortality actually increased during this time. Now I'm going to talk a little bit about artificial feeding, change course a little bit here. Ancient methods were dangerous. We had clay feeding vessels have been found as far back as 2000 BC. In the Middle Ages, it was not uncommon to use a cow's horn that had perforations in it at the tip. In the 1700s, bubby pots and pap boats were used. Bubby was an old world euphemism for breast, and so these were used. The problem with these is all of these were difficult to clean. So it was not unusual to have a mortality rate of up to about 1/3 of infants per year who were being fed artificially partly because they they couldn't adequately clean these vessels. But in the mid-19th century and the 20th century, changes occurred where feeding implements could now be more easily cleaned. This involved the development of glass bottles, leather teats, and then the vulcanization of rubber allowed for the development of rubber nipples for these glass bottles. And here you can see, an ancient vessel. Here's an infant in a mass grave, or a young child in a mass grave with a clay pot there, presumed for feeding. Here's the cow's horn. This is one of the pat boats. They would use these, and with this they could force or blow the milk into the baby's mouth, and it made feeding go faster too. This is a bubby pot, and it looks kind of like a coffee pot. The problem is the spigot here, you've got it down low, and it has these perforations in this knob on the end, and you really can't get in there to clean any of this. So here we have a development of some of the early baby bottles, and then development of nipples to go on those particular baby bottles. So with the invention of the modern feeding bottle and nipple, and the availability of animal milk, because animals were used to provide artificial feeding for these infants, and the change in society's acceptance of wet nursing, because they were seeing more deaths, especially with the poorer families farming out their children to women who had problems themselves adequately nourishing these children. All of this led to artificial feeding becoming a popular choice, and the medical profession began to focus on infant nutrition from an alternative medical milk source. So here we're going to talk about infant formulas. Now, animal milk was the most common source of artificial feeding until the end of about the 19th century. Obviously, it was dependent on available animals in that particular animals available to that particular family: goats, sheep, donkeys, camels, pigs, horses, but cows were most often commonly the common source of this alternative milk. In 1760, a Frenchman by the name of Jean-Charles Desarts wrote in his Treatise of Physical Upbringing of Children, he discussed and compared the composition of human milk to that of the cow, sheep, ass, mare, and goat. And based on the various chemical characteristics, he justified at that time, 1760, that human milk was the best source of infant nutrition. And yet, animal milk continued to be used. In 1865, the perfect infant food was developed, patented, and it was marketed. This was a liquid that consisted of cow's milk with added wheat flour, malt flour, and potassium bicarbonate. In the 1800s, Nicholas Appert developed a technique to sterilize food in sealed containers. And in 1885, John Meyerling developed evaporated milk, which also became a popular feeding choice and was highly recommended by pediatricians in the 30s and 40s. And granted, I didn't train in the 30s and 40s, but I can remember mothers coming in using the formula for evaporated milk to make formula to feed to their children. And it was one 13-ounce can of evaporated milk and 18 ounces of water and 2 tablespoons of Caro syrup. And I suspect that Dr. Bocchini, Dr. Bana, and Dr. Vancheri also remember this too from our training days. So very widely used. Now, a problem here, by the late 1800s, there were 27 patented brands of infant food, all of which were powdered carbohydrates in the form of sugars, starches, or dextrose that were added to animal milk, whatever animal milk was available. These foods were fattening, but the problem was that because this was just strictly carbohydrate added to the animal milk, there wasn't enough protein or fat in them for or minerals for the child's proper development. And the use of the artificial formula led to many summertime infant deaths because the milk that was left in the bottle spoiled, and they would keep feeding that to the infants. So summertime deaths increased. Now, in 1910 to 1912, because there was this increase in deaths with children, infants being artificially fed, physicians who were interested in child and women's health started emphasizing cleanliness and safe storage of the milk. And they went out to the dairy farms to improve cleanliness of the cows because that's where much of the milk was coming from. They also, during this time, ice boxes came into more common use in households, so now milk could be refrigerated. This artificial milk could be refrigerated that was being used to feed the babies. And during this time is when the rubber nipples and the glass bottles and rubber nipples came to be used more commonly. In 1929, the American Medical Association had a committee on foods, and which was formed to approve the safety and the quality of milk composition, and this forced these companies that were making these artificial formulas to seek the AMA's seal of acceptance, kind of like today's Good Housekeeping seal of approval. So the milk companies had to go to the AMA to get this seal of acceptance so they could market their artificial formula to the community. Then in 1932, advertising of these artificial milks to the public became regulated and was no longer allowed. And so during this time, this set the stage for the formula companies to really try to curry the favor of the physicians, to get the physicians to recommend their formulas to their patients. And so here, a positive relationship developed between the formula companies and the physicians at this time. And so by the 1940s to the 1950s, the physicians and the public together now regarded the use of formula as a well-known, a popular, and a very safe substitute for breast milk. And breastfeeding was on the decline. In the 1970s, also, although these formula companies weren't allowed at that time to market formula directly to the public in the U.S., they did aggressively market formula overseas. And so there was a global decline in breastfeeding. And that started generating negative publicity for the formula manufacturers. So that over about the next 30 years, public awareness campaigns started telling the public about the benefits of breastfeeding, and the medical profession came behind this. In 1984, Surgeon General C. Everett Koop convened a meeting about the importance of breastfeeding in society. Some of these United States groups that were involved in this, the Infant Formula Action Coalition, the National Council of Churches Interfaith Center on Corporate Responsibility. And as a result of these public awareness campaigns and increasing, the number of babies being breastfed in the U.S. started very slowly increasing, and also the length of time these babies were breastfed started increasing. Then in 1988, formula advertising directly to the public was now allowed again. So that created tension between the medical profession and these formula companies. Of course, the formula companies have lots of money. They were very happy to be able to go directly to the public because now the medical profession was starting to push breastfeeding again. And in 1990, the American Academy of Pediatrics released a statement against direct advertising by these companies, with their concerns being that, one, it created a negative effect on breastfeeding among the population. Two, it interfered with the physician's advice on infant nutrition to the physician's own patients. Three, it led to confusion amongst consumers because one company would say their milk had this and another company said their milk had that. and the consumers were kind of caught in the middle, not knowing, well, which formula is better. And this advertising also led to an increase in the cost of formula itself, which was a problem for families whose babies truly needed to be on formula. Now we're going to switch gears again a little bit to milk banks. In 1910, the first human milk bank in the U.S. Was founded in Boston. And these milk banks came about because physicians at the time increasingly recognized that infant morbidity and mortality were related to artificial feeding of infants. And this milk bank founded in Boston initially was not really a bank per se where women would come and leave milk, but was actually a home for lactating women who were paid to wet nurse infants in the hospital while these same women also breastfed their own infants that they had with them. The donors who lived in these homes, in this home here in Boston, were screened for tuberculosis and syphilis, and they operated directly under medical supervision while they were there in the home feeding these ill babies and young children there. Soon after it opened, however, it did truly evolve into a true milk bank with donors providing the milk and leaving it at the hospital, and then they lived in their own homes. And so these women were no longer directly wet nursing their patients. And this spread to other hospitals across the country where women would bring in milk that would be used to feed the ill children in the hospital. In 1943, the American Academy of Pediatrics published standards for milk bank operations, which included how to collect, how to process and store, and how to dispense donated human milk. And I've read the paper, and it was very interesting because much of what was done back then is still being done nowadays within the milk banks, and I'll talk about that a little bit later. But it's interesting how little has actually changed. Now, they did do some things. They did nasal swabs and throat swabs and vaginal cultures on these women frequently. And they required them to have chest x-rays and syphilis testing yearly for as long as they were donating milk. And those are things that are not necessarily done nowadays. Anyway, it was interesting reading. Then in post-World War II, up until the 60s and early 70s, the interest in banked donor human milk declined because artificial feeding options increased, especially the availability of new and improved preterm infant formulas. And so milk banks kind of fell, and human breast milk fell out of favor, and so fewer milk banks were around. And then in the 70s and 80s, the neonatologists saw that premature babies were surviving with human milk. And so hospitals started establishing their own in-house donor milk banks to provide human milk for these premature babies. In the early 1980s, we had 30 active milk banks in the U.S. and 23 in Canada. In 1985, the Human Milk Banking Association of North America was established as a nonprofit organization for milk banks in the United States, in Canada, and in Mexico to, 1, develop guidelines for operation of the milk banks, 2, provide a forum for information sharing amongst the milk banks, 3, provide the medical community with information about human breast milk, 4, encourage research about the human breast milk, 5, act as a liaison between milk banks and government agencies, and 6, to facilitate the establishment of new donor milk banks across the North America. However, by the 1990s, just a few years later, the number of milk banks in the U.S. had dropped to 5. Those in Canada had dropped to 2. So what happened? Well, what happened here was the threat of HIV, the increased incidence of hepatitis B and C, the return of tuberculosis, and drug abuse in North America. And so people became really worried that these illnesses were going to be transmitted to the infants, and there wasn't enough, it wasn't clear at the time as to whether or not the breast milk from these donor milk banks was safe to give to the babies, and so the number of milk banks decreased. However, in the 2000s, donor milk banking saw a resurgence due to an increase in scientific evidence of the benefits of human milk, as well as research on the effectiveness of pasteurization and freezing in the destruction of viruses and bacteria in human milk. In the 2000s, the World Health Organization wrote a document that's still being used now, titled Infant and Young Child Nutrition, the Global Strategy on Infant and Young Child Feeding, and it lists human donor milk as the first alternative for an infant or young child when the mother's own milk is not available. In November of 2010, the Canadian Pediatric Society endorsed human donor milk as the recommended alternative when the mother's own milk was not available. In December of 2010, the United States Food and Drug Administration's Office of Pediatric Therapeutics convened a meeting of national experts to discuss the safety, ethics, and regulatory implications of donor milk, and these experts endorsed donor human milk banking and deemed that informal sharing of human milk was unsafe. And in January of 2011, it was actually 11, that's a typo, the Surgeon General distributed a call to action to identify and remove all obstacles to the greater availability of safe bank to donor milk for fragile infants. And then in February of 2012, the American Academy of Pediatrics recommended that if mother's own milk is unavailable, despite significant lactation support, pasteurized donor milk should be used to feed infants. Now, these are the current human milk bank locations in our country, and are actually in North America. And we have, we have here, right here is the most recent one that has opened up. And there are several more that are in development. Generally speaking, it takes about 2 years from opening their doors before they can become an established and independent milk bank. During that 2-year period, they are mentored by another milk bank. And in the case of ours in Louisiana, in December of 2015, it opened its doors under the auspices of the Mother's Milk Bank of Austin, Texas. And that's where ours got its start. But now it's officially open, and it is the only one in the state of Louisiana. There are currently 24 milk banks in the United States and 3 in Canada, none in Mexico. In Louisiana, in addition to this formal milk bank, independent milk bank that we have here now, we also have milk depot sites in Baton Rouge and Lafayette and Lake Charles, where women can drop off their fresh or frozen breast milk, and then from there it is sent. Now it'll be sent to the milk bank in New Orleans. Before then, the milk was collected and sent to the Mother's Milk Bank in Austin, Texas. So, how do these milk banks work? The organizational structure is such that they're always overseen by qualified health professionals. And in the case of ours, we have Dr. Harley Ginsberg at Ochsner Baptist, who is the medical director of the milk bank, and then Shelley Thibault is a nurse, registered nurse, who is the director of the milk bank. And they include consultant panels, which must include neonatologists and or pediatricians, lactation experts, and experts in microbiology and or infectious diseases. These are people who have the education and training that's critical to the provision of safe donor human milk. These Consultant panels may also include, but are not required to include, other nurses, immunologists, pharmacologists, nutritionists, public health personnel, obstetricians, pathologists, food technologists, lawyers, and consumer representatives. These are all people who have agreed to be accessible to the milk bank director when appropriate. So, how do they work? Who are the donors? The donors are lactating women with surplus expressed milk. They can be healthy mothers of living babies. The baby itself that she has can be well or sick. However, if her baby is sick, then the mother can only donate her milk to her own baby. They can also be healthy mothers whose babies have died. And they can be mothers who have been surrogates. They're carrying someone else's child, and but won't have the child after birth, but they want to provide the milk that their body makes after birth to other children. They must pass a screening process, which is three-pronged. There's a written questionnaire. There is a face-to-face or phone interview, and this is considered to be a critical part of the screening process. And this part of this interview determines whether or not they're going to be able to carry out the sterile technique that's required to collect and store the donor milk that will then be passed on to the milk bank. And then the third part of the screening process is that the mother's blood will be tested for certain diseases, certain infections, and the milk itself will be tested. The donor screening first involves a consent form, and this consent form outlines several things. The donor will not be paid, and her milk will not be sold, but there will be a processing fee that is charged by the milk bank to the recipient. And this processing fee, as best I can tell from various sources, is usually in the $4 to $5 per ounce range. This donor is also told that the milk may not be given to infants, but it may actually be used instead for research. Her certain blood tests will be required of her. Her milk will be tested by a micro lab both before and after it is pasteurized. Her milk will also be tested for caloric content, and protein, fat, and carbohydrates are going to be looked at. Contents will be looked at. And she must understand that she has to donate the milk according to the written instructions that she's given for collection and storage. And she must notify the milk bank if there are any changes in status of herself or her baby's health, including new medications or herbal dietary supplements, any exposure to a contagious disease, or family obligations which require that she stop making donations. The written questionnaire, I was actually going to show you one because I was able to get one from someone who has donated to the milk bank, but then I actually bought material from the Human Milk Banking Association itself of North America, and in there they talk about the fact that they specifically prohibit public posting of the detailed screening documents, so I'm not going to do that. But I'll tell you in general what is in the literature to give you an idea of what kinds of things are asked about in the questionnaires. They ask for some basic demographic information. They want to know some information about the baby's health and growth history, including feeding information for the baby. They want to know the donor's health habits and medical history, especially as pertains to prescription drugs or recreational drugs. And included in this will be her use of alcohol, her ethanol intake. If she is taking daily more than 1.5 ounces of hard liquor, or 12 ounces of beer, or 5 ounces of wine, or 10 ounces of a wine cooler, that is problematic. So that's daily use of those of greater than those amounts. Also, it's going to ask about vaccinations and exposure to or testing positive for certain contagious diseases. Ask about her receipt of blood products or human organs or tissue products, whether or not she's lived in other parts of the world or been diagnosed with cancer, and what her diet is like. Is she a vegan? Is she gluten-free, dairy-free? Things like that. There will also be release of information forms. So the milk banks don't rely solely on the mother's interview and questionnaire that she's filled out. They're actually going to contact her doctor and contact the doctor of her baby and get some basic information from those people as to the health of this woman and her child. And this is, unless the child has died, that obviously won't happen, or if the child has, if she was a surrogate and doesn't have access to the child anymore. And then there will be serologic screening done on her blood, looking for HIV, looking for HTLV, hepatitis B, hepatitis C, and syphilis. Now, donors can be excluded for particular reasons. If they've received blood, organ, or tissue products in the last 12 months, they're not able to donate. If they use ethanol or liquor above the amounts that I previously told you about on a daily basis, they cannot be a donor to these milk banks. If they regularly use herbal preparations or megadose vitamins or prescriptions or over-the-counter medications, those are problematic, with the exception of some replacement hormones and contraceptives. A total vegetarian who does not supplement her diet with vitamins, her milk will not be accepted. If she uses illegal drugs, if she uses tobacco products of any kind, and that includes the patch or the gum or e-cigarettes, she can't donate. If she has silicone breast implants and if she has a history of chronic infections or systemic disorders of any kind, and particularly HIV, HTLV, or TB, she's not going to be able to donate. And then if the milk bank accepts her as a donor, it is expected that the milk bank will maintain contact with her at least every 2 months, some kind of ongoing communication to check on her, see if things have changed in her life, in her medical history, in her diet, with her baby, those kinds of things. Now, the milk is a living tissue, we know that, and it can be affected in any step by cleanliness, how it's expressed, the type of container it's stored in, the storage temperature itself, as well as the length of time that it's stored. Now, as I mentioned earlier, written instructions are provided to the woman that are very explicit, outlining how the milk is to be collected and how it will be stored. And it's collected using a clean technique where the pump is washed. You want to rinse it first, all the parts with cool water, which more readily removes the protein and fats, and then wash all the parts with warm soapy water. They can be washed in a dishwasher. They can also be sterilized in these microwave bags now that people buy and purchase and to put the pump parts in and throw into the microwave. The woman obviously needs to wash her hands before the collection of the milk, immediately before she collects it each time. Her breasts need to be washed only once a day in a shower or tub, but she does need to rinse them right before she collects the milk. The milk needs to be put into pre-sterilized containers once it is collected and stored in those pre-sterilized containers, and then it needs to be labeled with the donor identification information and the date of collection. And then generally it needs to be immediately refrigerated and or immediately frozen. Now, if she doesn't immediately freeze it, she can store it in the refrigerator up to 72 hours before it's frozen. And it is okay to take a container of frozen breast milk and pour cooled refrigerated breast milk on top of that to add to it, according to the guidelines in the book. And I've got the 2018 one, which literally just arrived at their headquarters Tuesday. So last Tuesday. So this is the current information. You can add cooled refrigerated milk to previously frozen breast milk, which I was kind of surprised to read. Anyway, then these written instructions are also going to talk to them, give them information about times when donating should not occur. For instance, if they have some kind of infection, if they have to take medications temporarily for something, and also lifestyle choices when donating should not occur. Perhaps they've gone to an LSU game and had a big fun time there that weekend with lots of drinking and stuff. Then temporarily that milk should not be collected and sent to the milk bank. So those are the things that are outlined for the mother. Then she's going to ship her frozen milk to the milk bank. It arrives, it's gradually defrosted in a refrigerator, and milk is not pasteurized, and if you've seen milk that's not pasteurized, you know that the cream rises to the top. So the milk will be pooled. All of the samples that she has sent will be pooled, and then it's going to be gently swirled to redistribute the fat into the milk. And then from each pool, a culture will be taken, and in general, pooled milk that has not been further processed will not be given to infants or children, other than the mother's own child. But there are some cases where apparently some babies are not able to tolerate the heat treatment that I'm going to talk about in a second. And so it can sometimes be given to infants and children, but it has to meet certain criteria. When on these cultures that are taken, it must grow less than 10,000 colony-forming units of normal skin flora, and there cannot be any pathogens present at all in that culture sample. If either of those criteria are not met, then the milk is discarded and it won't be given to anyone. Now, be aware that the FDA and CDC do not recommend dispensing raw milk without heat treatment, but as I said, apparently some babies don't tolerate it well. Now, once this milk a sample is taken for culture, then this pooled milk is divided into smaller, tightly capped containers with approximately the same amount of milk in each container. Then these containers are put into a bath to be pasteurized, and the pasteurization methods will kill HIV, HTLV, CMV, hepatitis B, hepatitis C, and as well as bacteria. And the pasteurization method that the milk banks use is called the Holder method, where the bottles, these tightly capped bottles, are completely submerged in a shaking water bath that has first been preheated to about 145 degrees Fahrenheit. And the last bottle put in has a thermometer attached to it. And once the temperature in that thermometer reaches 145 degrees, then the bottles will continue being agitated for an additional 30 minutes beyond that time. And at the end of that 30-minute time period, the bottles are rapidly cooled to 39 degrees Fahrenheit. And that's the Holder method of pasteurization. There is another one called that some people recommend, but the banks associated with the Human Milk Banking Association of North America do not use this other method, but it's called the high temperature short time method of pasteurization, where a higher heat is used for a much shorter period of time. And it's thought to degrade the nutrients less than the Holder method that's currently being used. Once the milk is cooled, then each batch is cultured again. And if the batch grows, if the sample from that batch grows any bacteria at all of the milk in that batch is discarded and will not be used. So there can't be any bacteria at all in that. And there may be a nutritional analysis done at this point. The donor milk can vary in caloric content from 12 to 30 calories per ounce, with fat content varying more than protein, which varies more than carbohydrates. Heating does have a significant effect on nutrients and infection-fighting properties, and the milk will still need to be frozen after it's been heated. But it is important for the sterility of the milk. And as I mentioned earlier, the cost is usually $4 to $5 an ounce. It's frequently covered by insurance as long as the baby is in the hospital, but once they're released, it very often is not covered by insurance. Okay. It's most commonly used for preemies, where it has been demonstrated to reduce the incidence of necrotizing enterocolitis. And then it's used for these other indications that you see up here. And if there is donor milk available from the milk banks after these kinds of problems have been taken care of, it can be also prescribed for these cases where a mother is not lactating, not making enough milk, or she's absent for some reason. If the baby has been adopted, or this was a baby of a surrogate mom, if the mom's ill, if there's a health risk to the baby from the biologic mother's milk, for instance, the mother has HIV, if the mother has died. So those are times when the milk can also be used, but only if those other needs have been first met. So what's happening now in society? Well, informal milk sharing has come about, and this has increased with increased internet access, spurred on with more studies showing the benefits to the infants of human breast milk and recommendations for babies to be breastfed or fed human breast milk for at least 12 months. So women across the globe were asking where they can get breast milk. And for mothers who were super producers, they wanted to know if there was something they could do with their excess breast milk. Now, in the United States, most body fluids and tissues are highly regulated by governmental agencies, but breast milk is considered a food by these same agencies, so it is legal to swap, buy, or sell it nearly everywhere in the United States. Interestingly, back in around 2010 or so, Craigslist and eBay used to ban the sale of bodily fluids, including breast milk. But when I was looking at this, even last night, there were ads on eBay for breast milk, frozen breast milk. So apparently that is no longer an issue. Now, with informal milk sharing now, what are the types of informal milk sharing that are out there? We've got a resurgence in wet nursing then, within families or between friends, and no money is exchanged at all. Or as employees hired by parents. There's an agency in the Los Angeles area called Creative Household Staffing, which added wet nurses to its employee listings registry in 2007 with a standard fee of $1,000 per week at that time. And so it's going, I'm sure it's increased now. And that wet nurse would generally be expected to live with the baby's family, and she would bring her partner and baby with her, usually also. Online milk sharing more than doubled in a 3-year period from 2012 to 15, with 55,000 women buying or selling online in 2015. And I can't even begin to imagine what the number is nowadays. Online costs average about $2 or $2.50 an ounce. Remember, I said the milk banks charge $4 to $5 an ounce, and generally it's only going to be available for hospitalized infants. So these are people out in the community who are purchasing it for a couple dollars an ounce, and I've seen it as cheap as 50 cents an ounce up to maybe about $4. There are varied reasons for online milk sharing. Sometimes the prospective donor failed the screening process that I talked about. There's less hassle for these women. They don't have to go through the screening process, and they can quickly get rid of their milk if they want more freezer space. And if they sell it, there's income from the donor. She may make quite a few $1,000s a year this way. Here are some of the informal milk sharing sites. Only the Breast is one. And I wish I had realized last week when I was looking at this site, there were some very interesting ads on here. One was a Harvard-educated lawyer who had several hundred ounces of breast milk, and she was selling hers for $4 an ounce. One was a man, and this particular one kind of bothered me because he was insisting on fresh breast milk, and he wanted to be able to personally meet with the donor at least twice a week to get the milk from her. And the way it was written was rather disturbing. I couldn't find either one of those on there when I went to this yesterday. But there are different categories depending on the age of the donor's baby, and what her diet is, and whether or not she's willing to be a wet nurse. And then what I call the anything goes categories, where women are willing to sell to men, or people who have cancer or supposed immune deficiencies, or people who just like the taste of it. Very interesting. Here's another one called Eats on Feets, which was a play on Meals on Wheels. This site doesn't use use exchange of money. This is strictly donations started by a midwife. It's global in scope, and it operates through Facebook pages where people share breast milk within their local communities. They recommend screening donors and safe milk handling and home pasteurization, but it's not required. This is another one, Human Milk for Human Babies, that is also a Facebook-based website, also involved with just donations. Here's one of the eBay ads I saw just last night, $345 for, I think this was 200 ounces of breast milk, frozen breast milk this person had, and the shipping cost was $120. Anyway, so what are the risks? Milk sold is more problematic than milk that is shared for a variety of reasons. Microbial contamination does definitely occur due to improper collection or storage or shipping. A nice study back in 2013 showed that 74% of internet milk samples that were bought for that study were colonized with gram-negative bacteria or had more than 10,000 colony-forming units of aerobic bacteria. 21% were CMV positive. They exhibited higher mean total aerobic and gram-negative and coliform and staph counts than milk bank samples. And a lot of times it was thought that these higher counts were related to the travel time to get the milk from the donor to the recipient. Also, milk is adulterated, usually with cow's milk. The study in 2015 showed 10% of samples bought for that study had at least 10% cow's milk in them. So if a mother is buying it for her child who is cow's milk allergic and she's expecting to get pure human breast milk, maybe so, maybe not. Then medications, ethanol, illicit drugs have been found in informal milk, and mothers may have illnesses that they may know about, maybe don't know about, again, being passed on to these infants. And then the donor's physical safety, like I said, especially this one ad just really concerned me about the safety of whoever might be willing to sell to this fellow on the ad I saw last week. So in 2017, we had a couple of international organizations. The American Academy of Pediatrics is one, and then the Academy of Breastfeeding Medicine is another that came out with position or policy statements. The Academy of Breastfeeding Medicine, first of all, certainly does not endorse informal milk sharing. But they recognize in society nowadays that this is happening. And so for the safety of people who want to get milk this way, they did have some guidelines. And that there be a mother-to-mother screening face-to-face or by phone interview, that the donor be reportedly in good health and only on medications and or over-the-counter things that are suitable for breastfeeding, and they recommend that the recipient have access to Lactamed or Medications in Mother's Milk by Thomas Hale to look up those things. They recommend reviewing the mom's prenatal screening tests to see if she was negative for hepatitis, syphilis, those kinds of HIV, those kinds of things. And then review her social practices with regards to like illegal drug use, drinking, etc. And then they recommended that the donated milk be home pasteurized using this particular flash heating method, which does not heat as long as the holder method that's used as the milk banks, unfortunately. So this was their position statement. And then the American Academy of Pediatrics policy statement, which was produced jointly by the Committee on Nutrition, the section on breastfeeding, and the Committee on Fetus and Newborn. This talks about donor human milk for the high-risk infant, that mother's own milk is preferred, but human donor milk may be used for high-risk infants, with priority being given to the smallest. So this is weight-based, not gestational age-based. Human milk donors should be identified and screened by methods used by the established milk banks. The donor milk should be pasteurized with post-pasteurization testing done. Families should be discouraged from direct milk sharing or purchasing human milk from the internet. And it occurred to me that mothers of babies in NICU could conceivably get milk from someone else and bring it in as their own, and then it be given to their infant child. So they do need to be talked to about this. And then use of human donor milk should not be limited by the ability of the family to pay for it. So going back to that case, now that we've gone through all of this, I just want you all to answer the question yourselves. What would you do in that case where this baby, mother wanted to breastfeed, mother's not available, a relative steps up who has a several-month-old child of her own and offers to breastfeed this baby in the meantime? I'll tell you that I did not allow it to happen, and started the baby on some formula. Very, very thankfully, the mother recovered quickly, although she was in MICU for a couple of days. But by about 17 hours after birth, that mother was breastfeeding her baby. And she had expressed colostrum in the meantime that was given to the baby in the meantime, in addition to the formula that we were using. And by the time she was discharged a couple days later, she was exclusively breastfeeding her baby. So that's
Great presentation. Questions? Dr. Bob?
It's a great presentation. Thank you. Absolutely. I have many questions, but I would say one comment and one question only briefly.
okay.
The immunologic value of the human milk is remarkable. Freezing does not reduce it. Pasteurization will reduce it by 20 to 30% only. It's not bad. The question is, the mother of the donor is not paying. Understand that?
Correct.
And the insurance can pay.
Correct.
What criteria that we can make the insurance pay for this? And the cost of each meal is $20, $30. That's very high.
Potentially. Well, if the babies, well, and I'll talk about formula-fed babies, who are taking maybe 6 to 8 ounces by several months of age. So at $4 to $5 an ounce, you're talking about 50 to, no, not even that much, $30 to $40 a day. I'm sorry, $30 to $40 a feeding. Yes, you're right. And so, yeah, it definitely becomes prohibitive. But that's short-term cost versus the long-term cost to society of having formula-fed babies with the health problems that they can have. I don't know. Again, I didn't look a lot into the issue of the insurance companies paying for it. Certainly I came across things where people talked about really having to advocate for particular patients who had medical problems that were going to continue after discharge, where they really needed human breast milk, and fighting with the insurance companies to pay for those. And a lot of times that's where some families turned to this informal milk sharing because it was so much cheaper, and when they couldn't get insurance companies to pay for it.
Mine was the cost and to see if they had any programs available, basically.
The conference is about to end.
What about if the mom did any like prenatal colostrum expression or had frozen milk left over from a prior pregnancy? Would that be allowed to be given to the baby in that circumstance?
I don't know about the prenatal colostrum expression. The frozen breast milk, apparently most of the milk banks limit accepting breast milk to milk that's less than 9 to 12 months old. It varies from milk bank to milk bank, and there are apparently a few that will accept it when it's up to 2 years, been frozen for 2 years, but apparently there aren't a lot of those. And I wondered if those are ones that are using the older milk for research, but I couldn't find any specific information on it.
I mean, for example, this mother, if it was her second baby and she was planning to breastfeed, if she still had frozen breast milk in her freezer from her prior child, could that breast milk have been brought in and given to her child in the hospital?
Well, I know that her other children are about 3 years old now, so I would seriously doubt she had any left. If she had turned around and become pregnant again, like some of our moms do within just a few weeks of delivering a baby, I think that would probably be reasonable. Right.
Then she could have had fresh milk going to the freezer when that baby was 1.
Right.
And then 9 months of pregnancy.
Yeah.
You know.
That I would have considered. So that I would have considered, but that wasn't the case here.
Yeah, some of them are tandem like still nursing.
Right. Yeah, we do have that, and that's a good point, and it is something that I would have considered allowing, but I knew that was not the case here in this particular instance.
What if the mother had, in some of these birth plans that they come up with, if she had included that and had given consent for a specific relative to give donor milk, would that have been allowed, or is that still not?
I don't know. I probably would not have allowed that here because of the liability to the institution. Do you have any thoughts about that? Yeah. Yeah. Because we wouldn't know anything about the donor, and I don't know that we could sanction that. So.
Do we have ways of like testing the donor milk here?
I can't hear you.
Do we have ways of like testing the donor milk here? Like if they were
No.
adamant about it? Okay.
No. Other than, micro lab, but, well,
Too late, right?
We have a screening process.
Like a week later, here's your culture.
But not donor, no
Yeah.
donor milk.
So I think, it's obviously apparent in like the medically fragile or premature or NICU babies that they should certainly be going to the milk bank. But if it's a term baby that the mom had some sort of complication, what are the odds of this baby getting the milk from the milk bank anyway? Like they wouldn't qualify as being the smallest weight or the sickest kid.
The odds are
like
very, 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 very low.
Right, so they're not going to qualify to get milk.
No, and in
It's really
fact,
not an option.
in fact, what I read was that many times the babies no longer, the preemies no longer, or the little babies no longer qualify for donor milk bank from the nonprofit milk banks once the baby reaches 32 to 36 weeks gestational age. And again, that's because of scarcity of supplies. So even if they're in the hospital longer than that, 36 weeks gestational age, they're not going to get the donor milk anymore from the milk bank.
It's just the nonprofit ones, though, because it seems like it seemed really readily available. In Colorado, it seemed like all the NI babies were. I'd never seen formula in the NI there. It was straight donor breast milk.
Colorado has member banks there. I don't know a lot about the for-profit milk banks other than one called Prolacta, which actually takes the milk that it gets and it makes human milk fortifier, which our NICU does not use. We use the bovine milk fortifier, and that's because of the expense. Nitin? correct?
Yeah, it is, the cost is a big,
Yeah, big difference in cost.
even the unit which using is only up to 32 weeks, as you said.
So,
The cheapest is the mother's herself.
right.
What is the breastfeeding rate initially and then 3 months around the other
I almost put that slide in here, and I apologize because I can't remember. It's greater than it used to be, but we've still got a long way to go.
The plants put that after 6 months on. And the child hospital, you know, I think the other state hospitals, in the late 70s, the rate of breastfeeding in them was almost zero. Because a company, formula company, volunteers to get the milk, the formula for free.
Right.
Provided no other companies give in some, which is a very bad policy. This fight continued for a few years to allow another company to donate. So I did not call it really donating the formula. They are manipulating and controlling.
It's advertising and marketing.
And every woman that comes out from these hospitals were given a good supply of samples and later by mail.
Right.
That is the big problem.
Right. Yeah.
All right, due to the hour, we'll have to stop, but thank you very much.